Thank you to Philippines Orthopaedic Association for giving me this opportunity. I am Dr. Prashant Narhari from Penang, Malaysia. I'm presenting today on a topic sports and recreational activities in Malaysian orthopedic oncology patients. So I'm sure a lot of you know about this guy, one of the famous sports person in Malaysia. So yes, he is the world #1 in badminton. He was the world #1 in badminton. So throughout this presentation, you will be seeing quite a lot of my patients who follow his footsteps. They'll be playing a lot of badminton. And besides badminton, in Malaysia, they are also famous for this sports called sepak takraw. But as you can see, even a normal person might not be able to do this type of sports activity. You can see the guy is almost head over heels there. So when we talk about orthopedic oncology, the first thing that comes to our mind is we do big resection and we replace big segment of bone. And how can this patient actually, have a good functional outcome after this type of surgery? So what we aim to cover, hopefully, is the first question is, can patients with orthopedic oncology bone reconstruction actually participate in sports activity? If yes, how active can they be? And what is the effect of these sports on the implant survival? And as orthopedic oncology surgeon, what are the things that we think about these sports in endoprosthesis reconstruction? So we will take this lecture through the anatomical area. So we'll start with the hip, knee, then we'll go to the upper limb, a little bit on biological reconstruction and joint sparing surgery in a giant cell tumor of bone. Okay, let us start with the hip. So Hopash et al. Has actually reviewed 16 patients with a minimum of 5-year follow-up. Basically, what they noted is out of the 16 patients, 14 were able to do sports activity, and 11 of them were actually able to do pre-surgery sports activity. Of course, this is at 5 years follow-up. And they also concluded that for proximal femur endoprosthesis replacement, bipolar articulation gives the best stability, and which in return gives the best functional outcome. So let us look at some of our cases, right? This is a guy who had proximal femur GCT, resection and endoprosthesis reconstruction was done. You can see that he easily squats and stands up. He has very good hip range of motion. This is him at 1.5 years post-surgery. He enjoys jogging, playing badminton, and he's a Muslim, so he prays as usual because he can squat down. You can see how easily he picks up the ball. Yeah, he moves very swiftly. What about knee endoprosthesis? Okay, the same group actually, but this time lung. He actually reviewed distal femur and proximal tibia, and they actually noted no functional difference, no outcome in the functional, no difference in the functional outcome in both this location of tumor. So they had 27 patients, and 24 out of that 27 were actually able to return to sports, right? And what they noted, interestingly, is most of them were not doing much sport at 1 year post-surgery. It's only 33% who were able to go back to sports, but this steadily increased up to 89% at 5 years. And out of this 27, 14 of them actually had revision surgeries, and that did not have any influence on the patient's activity. So let's look at our case. This is proximal tibia osteosarcoma, wide resection endoprosthesis reconstruction. We can see she has very good knee range of motion and excellent extensor mechanism. So she hasn't started on sports yet, but I'm sure she will do very well. Another patient, much larger tumor in a younger patient. So we actually had to put a customized proximal tibia, non-invasive growing endoprosthesis. This is the intraoperative picture showing the extent of the dissection. And this is him at about a year with no limb length discrepancy. He has a range of motion of about 0 to 90 degrees, as we can see from this video. Good extensor mechanism. And this is him at 2 years post-surgery. Again, enjoying badminton. He has unlimited walking capacity. He has a bit of a limp, but nevertheless, he does quite well with it. Of course, intercalary resection tend to do better because that preserves the hip and the knee joint. So this is a guy with an E-wings of the femur. We did an intercalary resection and reconstruction. He was a professional football player. He doesn't play professional football anymore. However, he still can play some football. Let us move to the upper limb. So proximal humerus endoprosthesis, right? So the important thing in proximal humerus endoprosthesis is basically to get a stable shoulder, right? We know that these patients do not get very good shoulder animation. What they get is hand and elbow function, but getting a stable shoulder is very important. And this paper by Lang again actually shows that mesh or Trevera tube reconstruction actually gives a better functional score compared to soft tissue reconstruction alone. Migration was seen less commonly, and they also noted that there was no difference between the Trevera versus the mesh group. And interestingly, again, we can see from this graph here, right? Most of them did fairly bad at 1 year, but this functional outcome actually increased at year 3 and up to year 5. At year 5, most of them were able to go back to low or medium impact, which they had preoperatively. So whether you're putting in endoprosthesis or an allograft like this case, right? I think what is important is to make sure the shoulder joint is stable with mesh reconstruction. So we prevent this type of sagging happening. Taking this a bit further, this is a patient who had E-wings of the scapula. We did a total scapulectomy. Basically, we took the proximal humerus and sling it with a mesh to the remaining clavicle, right? Hanging shoulder procedure. And this is her at 6 months post-surgery. Right? So she get about 45 degrees of shoulder abduction. Nevertheless, this is a very stable shoulder. A proximal radius, E-wing sarcoma, treated with wide resection and a free fibula graft, united very well 6 months down the line. And he has excellent elbow and wrist function. That is him playing ping pong. His MSTS score at 1.5 year post-op is 29/30. We talk a little bit about joint sparing surgery, especially when we talk about giant cell tumor of bone. Okay, with the advent of denosumab, which can be given as neoadjuvant, right, we actually can salvage more joints than previously. So we started by giving 7 doses preoperatively, but we noted that most of the tumor tend to become very hard for curettage, and we have actually gone down to 2 doses at the moment. So let me share some of the experience that we had. So this is a young girl with proximal tibia giant cell tumor of bone. She was given a couple of doses of denosumab, which actually calcified the lesion. Eventually, the patient went in for extended curettage, cement, and plating. So this is her at 2 years post-surgery. She wouldn't have got this type of range of motion if we did a proximal tibia endoprosthesis. And this is her 3 years post-surgery. Right? So she enjoys jogging, badminton, and swimming. Similar diagnosis, giant cell tumor of the calcaneum, extended curettage after denosumab and cementation. And this is him at 1.5 years. He can do almost any sport, swimming, gym, skipping, badminton. He can even play futsal. So what are the concerns over sports activity when it comes to endoprosthesis reconstruction or tumor surgery in general? So what the surgeons are worried about is actually periprosthetic fracture, loosening, polyethylene wear, and prosthetic failure, right? So this review by this group actually showed by the More Sports Expert Opinion, which was an online survey, actually showed that the surgeons see fewer complications than what they actually expected. So we can see from this graph, right? The fear is more than what the surgeon has witnessed in all categories. So for example, if we talk about early polyethylene wear, right? So about 70% of the surgeon are worried about it, but hardly 50% have seen it. So what do we know about sports when it comes to orthopedic oncology procedures, right? We know that many patients can go back to sports, right? And it takes about a year-long rehabilitation before they can go back to sports. There is no uniform recommendation of which sport can be given to which patient. Rather, the treatment should be individualized. What we don't know about this, how active should they be? We don't really know this, but probably much more than what we currently tell them. So back to our 4 questions that we started. Can patients with orthopedic oncology bone reconstruction participate in sports? Yes. Good rehabilitation in the first year following surgery is very important to achieve this. How active can they be? At 3 years, most can participate in pre-surgery level activities. What is the effect of sports on the implant? We don't really know this, but what do we think about sports in endoprosthesis reconstruction? We know that the surgeon tend to be a little bit more concerned than what we ought to be. With that, thank you.